Wow. Thank you so much, Dr. Marin. You're going to listen to me after that. That's really a tough act to follow. I'll do the best I can. I deal with very low-risk people largely. So here we are in a complex case, and I'm going to talk to you about a population that largely has normal coronaries. So it is what it is. You see them as well. So let's go. Some disclosures. I highlighted the ones that I've gotten paid for. Most of the talks, as you all know, we don't get paid for. So here we go. Roxana asked me to not only talk about CT, but also to cover the guidelines, the chest pain guidelines, which were very controversial. I was a member of the guideline committee. I chaired the section on imaging. So I'm going to give you the perspective on CT, how it advanced through the indications, as well as throw in some data on FFR-CT. And so here we go. Overall, the guidelines emphasize this algorithmic pathways in working up patients. Sometimes they were perceived to be perhaps a little cumbersome, but there was a lot of data to cover. So in the acute chest pain, there are 11 randomized trials with CTA. Versus a standard care, which is largely stress testing, and the intermediate risk patient with no history of coronary disease. I'm going to cover the stable chest pain guidelines, which are even more controversial, where there are 9 randomized trials. But let's look at the CT use in the ED. There are, as I said, 11 randomized trials. Most of them very small. The evidence that was accumulated in the clinical practice guidelines focused in on 2 key results. You can use CTA more promptly, get a quicker diagnosis, and you can promptly discharge patients that have no coronary disease. The no stenosis, no plaque, or minimal coronary disease can be, and that's the lion's share of the patients, can be promptly discharged. You don't want to discharge a lot of people and have them come back. And the randomized trial evidence says no safety issues with CT, either death, MI, repeat ED visit, or ACS over a near term. 2 new trials, the Verdict and Rapid CTA, they expound on those previous data, and except they're in higher risk patients. Verdict trial was non-ST segment elevation, ACS, AMI, dynamic ECG changes, or a gray score greater than 140. Results very similar. Only earlier use of CTA for accurate and prompt discharge. Same message. High negative predictive value. Same message as the data that's used in the clinical trial in the clinical practice guideline. Rapid CTA was even looking at higher risk patients with a suspected or provisional ACS diagnosis, either had to have known coronary disease, an elevated troponin, or abnormal ECG. No difference in outcome. Consistent pattern in the literature. So that's what you see. You see right here, 13 randomized trials, all with the same result. No difference in outcome. Early discharge, accurate discharge when compared to a standard care approach. So here you see CTA, that message in this algorithm, very clearly class 1A indication, highlighted in red, prompt discharge without safety issues. Important message. Is it the definitive message? No, but it's still an important addition to the literature. Now, you can also use CTA in the patient who has had prior testing if they've had a prior inconclusive or mildly abnormal stress test within the year. Current state of stress testing. I think we've seen some illustrative cases where stress testing wasn't very helpful on those patients. Low rate of ischemia in general in the people that undergo stress testing. We've seen in my career, on average, ischemia has gone from about 40% to about 5%. And you imagine all the stress tests are done in the United States, and we're seeing about a 5% rate of ischemia. The rate of obstructive disease in the symptomatic evaluation is quite low. You deal with very sick patients. Overall, in a stress testing or CTA lab, only about 1 in 10 has obstructive disease. And what happens with that population is when they get referred to the cath lab, you see a very, very high rate of no obstructive. This is a very inefficient and ineffective pathway that we have going on right now. So what happens if we switch to this using CTA? So here's the data for CTA based upon the guidelines. There are 9 randomized trials, a very recent one, the discharge trial, which was published about 2 months ago. There are 2 types of trials. One in the elective patient using CTA as a replacement instead of invasive coronary angiography. The results all consistently show no difference in major adverse cardiac events at around a year. The discharge trial, which was recently published, emphasizes another key factor, and that is there's no difference in MACE, but there's around a 70% reduction in procedural complications. All of you know that procedural complications are quite low, but they're even lower with CTA. That just is a no-brainer, right? But probably the more controversial types of trials have been CTA versus stress testing. There's no difference in near-term effectiveness. So CTA has similar results. It's a similar strategy which can be employed as compared to stress testing. The planned secondary analysis, these are planned analysis, show an improved long-term outcome. And here you see the Scott-Hart result at 5 years on the bottom right. And we saw a 40% reduction in 5-year rates of coronary heart disease, death, or myocardial infarction. This is incredible. You all demonstrate in trials all the time improvement in outcome. But you have to know these are the first trials that we have seen in lower risk populations that we can actually make a difference based upon an imaging guided strategy, which is amazing. We certainly need more information. The Scott-Hart, that impact of reduction in CHD death or MI was tied to a greater use of statins and aspirin in those patients with non-obstructive plaque and obstructive coronary disease. So in PROMISE, a planned secondary analysis showed the same pattern as in Scott-Hart, but in a diabetic population. Fascinating results and really, really very controversial in terms of the guideline. So here's the guideline. So now you have two options. You have a CTA strategy versus a stress testing strategy. Most of you are well entrenched in terms of stress testing strategies. A lot of my career in the COURAGE trial, BARI-2D trial, and ischemia trial also emulated those research patterns in terms of guiding the use of stress testing to guide interventional practices or medical therapy. But now we can throw in there an alternative, an anatomic strategy, one that is very different than what you have seen historically over the past 30 or 40 years. But let's talk for a moment about the use of FFR-CT, and I'd like to take the perspective really on how the guideline committee assessed it. Now, it is FDA cleared, the use of FFR-CT, so it has 3 controlled clinical trials that led to its approval. It has 2 very large multinational registries. I'm just showing you the 1-year results from the ADVANCE registry published by Manesh Patel in the ADVANCE trial group, showing an increased risk of cardiovascular death or myocardial infarction at 1 year in patients that had a reduced FFR. The hazard ratio is about 4-fold elevated. There are some other CTA measures which I think probably hold more promise, including the delta of the FFR across the lesion. Some people also like to use the delta across the vessel to get more an idea of diffuse changes. But importantly, what has happened and what has transpired in the literature is there's been a lot of fluctuations on where you measure the FFR-CT, which has led to a lot of variability and accuracy. We've come to the conclusion that you should measure it close to the stenosis. I know that sounds like brain surgery that the imagers came up with, right? We figured it out, you should measure it close. But people were so eager to get a reduced FFR that they would often go much more distally, and then they showed a discordance with invasive FFR. So what are the strengths? There's a high negative predictive value to exclude ischemia. That's important in the patient you don't want to send to invasive coronary angiography. It is a one-stop, so it's all post-processing. There's no additional, any kind of additional radiation or imaging that you have to do for the patients. The CT data is sent out with a somewhat prompt measurement, a couple hours. Now, you say, well, that's still a couple hours. I want the decision to be real-time. But if you compare it to sending the patient to another stress test, then it is more efficient, and from a patient's perspective, it does actually result in just 1 test instead of 2 tests. So there's no additional testing with FFR-CT. Limitations, the correlation, the concordance, because of the issues on differences in measurement, have been moderate between invasive FFR and FFR-CT. All of you in the room, I bet, would have heard cases or know you have used this yourself, and that's an important limitation when you use this for revascularization decision-making. The other major challenge is that you won't use it very much. So if you decide to use it, remember our cohorts in the outpatient sector, they're lower risk. The prevalence of coronary disease is low, 10, 15%. So you might use it in about 10% of patients. So you're not going to use it that much. You're going to have a tough time because Medicare reimbursement for a CT angiogram is around $400, and you want to add on an $800 plus costly FFR-CT. So that's a negative in my world, where $800 is a lot, and we certainly need randomized trials to show improvements in outcome. So where are we? CT has got a Class 1A indication as a CT, as a first strategy for the evaluation of stable chest pain, no known coronary disease. You can take that very traditional approach. You could even think about using CTA after ischemia testing, like we did in the ischemia trial, but you could also think about a pathway of CT that leads subsequently to invasive coronary angiography. So, whirlwind tour of CT, lots of evidence, strong evidence, really more stronger evidence than contemporary evidence than for any other imaging modality. It is the test for suspected coronary disease, and I think the reason for a CT first strategy is that you'll get more patients into the cath lab who have obstructive disease. You can more selectively use stress testing, even FFR, to be more lesion specific, and it results in a more cost efficient strategy. So thank you for letting me discuss this today. Thanks.